Hello. In this lecture, we are going to circle back to capillaries and look at capillaries and tissue perfusion and come back to looking at those pressures we talked about previously. Now, we know that capillaries are the most numerous of all the blood vessels. There's approximately 60,000 miles of capillaries, and we know that they connect arterioles to venules. Remember that they have the thinnest walls, so they have extremely thin walls. In fact, that wall is only one layer. The wall of a capillary is called the endothelium, and it consists of only the tunica intima. Remember, one layer of simple squamous cells. Capillaries have the slowest flowing blood as they kind of go through because they need time to exchange nutrients and waste with the tissue cells. So these are our exchange vessels. Now, when we look at capillaries, there's different types of capillaries by their structure. So we have what's called continuous capillaries, and continuous capillaries are called continuous because they have tight junctions between those cells, those epithelial cells. And so what this means is that they're not very leaky at all. So they're more impermeable. And you can see some areas where we might have continuous capillaries. One example would be up, especially in the brain, when we don't want everything to kind of leak out of our blood and go into our brain. But these are going to be found, like I said, in nervous tissue, and they're going to have the tight junctions and be the most impermeable. Now that's the opposite of fenestrated. If you look at the fenestrated capillaries, they have pores. See these little holes? They're called fenestrations. So these are the most permeable, and these are found in areas where we need a lot of fast exchange. So we might find these in our kidneys, in our small intestine, where we're absorbing a lot of nutrients. And then a sinusoid is a capillary-like space. They're just large open spaces. We see these in the liver. You saw them in bone marrow when you saw where that red bone marrow was, and you had like the trabeculae and the spleen. So these are basically just open spaces. So if we look at the anatomy of a capillary, we have the arteriole and we have the venule. So as the blood flows through the arteriole, it will branch off into this network of capillaries called a capillary bed. And so as the blood flows from the arteriole toward the venule, it flows through the capillaries first. Now, when we look at these capillary beds, we have a couple of options that can occur. So in this picture A, notice you're seeing the blood is flowing through all the capillaries. So we would say we have high tissue perfusion here. Whereas if we look down here in B, notice there is no blood going through that network of capillaries, the capillary bed. In B, notice the blood goes right from the arteriole directly to the venule. So there's two things that can happen here. So there's something called a met arteriole. And the met arteriole is just the beginning of the blood flow going into the capillary bed. So we have an arteriole, and then the branch coming off is the met arteriole. So it's the beginning of this channel, which is running directly over to the venule. Now, each of these capillaries here is going to have a sphincter, and sphincters are smooth muscles, so we don't control them, and their job is to open or close to control if the blood is going to flow into the capillary bed or be shunted directly across. Now, this is an example of autoregulation. You don't have to think about this, and we'll talk about the factors that might close the sphincters or open the sphincters. So when the precapillary sphincters are all open, blood is allowed to leave. It flows into the true capillaries. And so we call these true capillaries. So this is the capillary bed or capillary network when the blood is flowing through them, and we have this tissue perfusion. So when we have active tissues, we want blood to flow through true capillaries. So when we're exercising, we want the blood to flow through our true capillaries in our muscle, in our skeletal muscle. But when we're exercising, we don't really need blood to go to our stomach and small intestine as much because we're not trying to digest food, we're trying to exercise. So the other option is if those precapillary sphincters all close, now the blood can't get into the true capillaries, so it's shunted. It goes directly from an arteriole to a venule. And when this happens, we say it flows through what's called a vascular shunt, and some books might call it a thoroughfare channel. Vascular shunt's probably a better term. And so now what's happening is we're shunting the blood from the arteriole to the venule, and we are not perfusing the tissues with blood. And so this would be something we would expect in digestive organs during exercise. Well, think of the opposite. What if you eat a meal, right? So when you eat a meal and you sit down to dinner or lunch, now what we want is we want this tissue perfusion to happen in our digestive organs because we want to digest our food. And we don't want to send all that blood to our skeletal muscle. So if you've ever eaten and then went on a run or did something foolish like that, you might notice that you throw up or you don't feel well. Because when we exercise, we're increasing blood flow to skeletal muscle and decreasing digestive organs. And if you have food in your digestive organ and you're not digesting it, your body usually tries to just get rid of it as quickly as possible. So I mentioned this was called autoregulation. So autoregulation means that you don't have to consciously control it. It's going to occur automatically. And so what we're looking at is basically the vasodilation or vasoconstriction to control blood flow and blood pressure. So there's two things that we're looking at for this. So one, we're looking at that precapillary sphincter. Is it going to be open or closed? And number two, remember, we can also vasodilate or vasoconstrict the entire arteriole to the area. So anytime we need to increase blood flow, right? If we vasodilate, we are going to have tissue perfusion and we're going to increase both oxygen and nutrients to the area. So that's pretty important that that occurs. And we know that if we vasoconstrict, then we're decreasing the blood flow to an area. And so when we're looking at trying to cause tissue perfusion, one of the main ways we do it is through vasoconstriction, vasodilation. Now in your notes, you have the terms that say vascularization, angiogenesis, and regression. So just know that if you see the term angiogenesis, that means the formation of new blood vessels. So the degree of vascularization depends on how many blood vessels you have in the area, how many capillaries. So our body can grow new blood vessels. It can also get rid of them. That's what regression is. And so the whole goal is to always make sure that the active tissues are getting the blood. And then the way we do this is by vasodilating and opening up those capillary sphincters, those precapillary sphincters, to increase blood flow. So if we think about factors that would cause the vasodilation, so they're going to open up the arterioles and the precapillary sphincters. So when we vasodilate, we are going to increase tissue perfusion. Well, if you look at the factors that trigger this, it kind of makes sense. Anytime we have low oxygen, well, if you have low oxygen in an area, you need more blood, right? Because the blood has the oxygen. Maybe the nutrient levels are low. Maybe there's too much CO2, too many hydrogen ions, too much potassium or lactate. So if the CO2 levels are too high, that's a sign that we need to increase blood flow because we need to remove the CO2. We also know that whenever our CO2 goes up, it's actually going to produce more hydrogen ions as well, which would make our pH fall. So that's usually a factor of having too much CO2. Now, if we have a lot of potassium, where does the potassium come from? Well, remember when we look at cells, cells have a lot of potassium inside. So when a cell dies and it ruptures, it releases that potassium. So if your potassium levels are elevated in an area, it's usually a sign of cell damage. And then lactate levels would be elevated if we didn't have enough oxygen in the area. Because remember, if we're working anaerobically, then we're going to produce lactate. So these are all signs of tissue that needs more blood. And so it's perfect that when these substances are produced, they automatically trigger vasodilation and relax the precapillary sphincter to correct the situation. There's some chemicals that also do this. Histamine and bradykinin you learned in the inflammatory response. Well, remember that inflammation primarily happens because of vasodilation. When we vasodilate blood vessels, and histamine even makes them very, very leaky, that's what caused the heat and the redness and the swelling for inflammation. So it makes sense. We already said NO, or nitric oxide, is a very powerful vasodilator. We mentioned that even the red blood cell can release this, anytime it picks up hypoxia. So if you think about the factors that would cause the vasodilation and relaxation of the sphincters, it makes sense that it's anything that's basically sounding the alarm, hey, I need more blood, I need more blood. Now, don't worry too much about the hormones and the neurotransmitter piece on this one because I'm not really getting into that. Now, what might vasoconstrict? What might be a sign of, hey, I'm good, I don't need more blood? Well, just the opposite of everything up there. So we would vasoconstrict if the O2 levels were elevated or if there were plenty of nutrients, right? That makes sense. We would vasoconstrict. If our CO2 fell or hydrogen fell or potassium, then we're not going to worry about sending blood there. And then endothelians, prostaglandins, and thromboxanes, you should recognize these from when we talked about the first step in clotting, the vascular spasm. Remember that when you damaged the blood vessel, there were endothelians and prostaglandins, and they caused the immediate vasoconstriction. And that was really important because its job was to decrease blood loss. So if we look at our blood supply at any given time, we can change how much blood goes to our organs. We know that the brain, by the way, stays pretty constant. You don't really want to shunt blood away from your brain, right, when you're doing something. So we have about 750 mLs per minute. Notice the heart at rest versus exercise. When we exercise, we need more blood, right? We have to pump more blood. The heart has to work harder to get that blood out to our muscles. The skin changes quite a bit. So when we're very, very cold, it can be as low as 500, but it can go up to, we'll say 2000 and keep it simple. So we know when we're very, very warm, we vasodilate, right? The skin is really important in helping with thermoregulation. Kidneys, normally it's usually closer to about 1200. So we'll say 1200 here, mLs per minute. Now at high exercise, you can decrease blood flow to your kidney a little bit. Now, as far as our abdomen, our digestive organs, that's going to depend on if you're digesting your food or exercising, right? That would change quite a bit that way as well. And then notice with muscle, that skeletal muscle, active muscle, gets more blood. That's why when you exercise, your skin gets warm and you might turn red. Now, there's a reflex I want to mention briefly. This reflex is not as big in this unit. This reflex, though, will come back when we study the kidney. It's a very important reflex when we're looking at what's called the nephron, and it's a stretch reflex. So what we know is that it's an automatic response. So when we look at smooth muscle, it's an automatic reflex that either makes it contract or relax. So it's causing constriction or dilation of smooth muscle in response to stretch. So it's a stretch reflex. And the purpose of it is to maintain blood flow into capillaries. So if we have a arteriole and it's sending blood into a capillary bed, we want to keep that the same. So if our blood pressure were to increase, then you probably understand that you would increase blood flow into your capillary bed. Well, that might overwhelm it. So this reflex works that if your blood pressure goes up, it's going to vasoconstrict the arteriole to make sure the flow stays the same as it was. Or if your blood pressure should drop suddenly, so if my BP were to decrease, so we'll just do it down here. We have an arteriole feeding into a capillary. So now if blood pressure decreases, you can imagine that less blood would flow, right? We wouldn't get enough blood. So in that situation, we're going to open up the blood vessel and vasodilate to maintain flow. So it's a little counterintuitive to what you were thinking about in systemic vessels. This is a specific reflex. It's going to happen anytime we have a capillary network fed by an arteriole, which you will see in the kidney, and it's just a stretch reflex, and its job is to keep the flow, keep the arterial diameter pretty constant in response to pressure changes, so we maintain blood flow into the capillary. Now, we're going to wrap up by looking at capillary exchange. So we already said they're the exchange vessels. We said they have thin walls. We can see a typical capillary here. They use diffusion. They can use some active transport and osmosis. We're going to focus on filtration. So filtration, remember, is pressure driven. So it's just pushing materials through based on pressure. So the materials are moved from a high pressure to a low pressure. And when we look at filtration, really the limiting factor is just the size of the molecule, because you have these little pores. And so the molecule is small enough to fit through the pore, it goes. And if it's too big, it won't go. And in 119, I always use the example of making coffee. So you have your coffee filter, and you put your coffee grounds in it, right? The coffee grounds shouldn't be in the coffee. But if you poke holes in the filter, right, if there's damage to that membrane, now the coffee grounds are going to get through. So we always say it's non-selective and it's based on size. So as long as everything's functioning normally, only small things are going to pass. So there are two pressures that are responsible for filtration. Now, we're looking at capillary hydrostatic pressure and we're looking at osmotic pressure. So when we're looking at this, we know that the hydrostatic pressure, you probably remember this, it's the force, right? That's going to push things out of the capillary. So it's going to push molecules and materials out. And we know that capillary hydrostatic pressure, so sometimes we just say CHP, is dependent, so we'll say it's directly proportional to your blood pressure, because remember, blood pressure is the literal force pushing materials through. So if we look at a simple picture for a minute, we have our arterial end here, right? So we have our blood coming in, and then we know that it's going to pass through the capillary bed and it's going to leave through the venule end. Now, when we look at hydrostatic pressure, because hydrostatic pressure is dependent on blood pressure, and remember that blood pressure decreases as you go from an arterial to a venule, notice the hydrostatic pressure falls as the blood moves from the arterial to the venule. And this is because we're further away from the heart, and we know that pressure decreases as we flow in this direction. And so if we're looking at the hydrostatic pressure at the arterial end, it's closer to 35, that force pushing things out, where on the venule end, it falls to roughly 15. So the pressure falls as we go through the pipe. Now, the opposite pressure is the osmotic pressure. And the capillary osmotic pressure, remember, is always pulling things back in. So sometimes it's called the blood colloid osmotic pressure. So you might see it as COP for capillary osmotic pressure, or BCOP. I usually just write COP for this one. Now, that one ranges depending on what book you read. So this one's saying 25, and in a minute, we're going to go to the picture from your book, which is, I believe, using 22. So that is most dependent on plasma proteins. So remember, one of the jobs of plasma proteins was to maintain the osmolarity, the osmotic pressure of your blood. And you might remember that the most abundant plasma protein is albumin. So albumin's, one of its main jobs is to always be in your blood. It should never leave because it's maintaining the osmolarity. We need stuff in our blood to maintain the osmolarity and that osmotic pressure, and that should be constant. It does not change from an arterial end to a venule end. The only way that would change is if it was leaking out. And it shouldn't leak out because it's too big. Now, if you poke holes in your coffee filter, if I have damage to my cells, albumin might leak out. And then think about, do you remember where it was made? Albumin was made in the liver. So we also need to have a healthy liver to make sure we maintain these balances. And so what we look at is called the net filtration pressure. And it's literally just which number is bigger. That determines where the fluid goes. So notice over here at the arterial end, I have a force of 35, right? Pushing things out of the capillary. Well, that's opposed by the osmotic pressure of about 22. So at the arterial end, my force pushing things out is greater than my force returning them. And if you do the math, you'll see the pressure difference is about 13. So materials, molecules, water, leave at the arterial end. But remember, as I come through, my hydrostatic pressure is going to fall. So anytime my hydrostatic pressure is greater than my osmotic pressure, molecules leave. However, anytime my hydrostatic pressure, so remember it's going to drop So now as we come over to the venual end, my capillary hydrostatic pressure is falling. It's down around 15. And remember, that's the force pushing things out. But my osmotic pressure pulling things back in, that doesn't change. That's still 22. So now, which force is greater? Well, if osmotic pressure is greater than hydrostatic pressure, now material is pulled into the blood. So it's a perfect setup, whereas blood flows through, materials leave on the arterial side, and then wastes and molecules are pulled back in on the venual side, and then it leaves. Now, one thing you're going to notice, though, is that the pressures are not equal. If we look at the arterial end, our net filtration pressure, right, pushing things out, was around 13, 35 minus 22. And if I look at the venual end, now it's different, right? I had a force of 15 pushing out, but 22 pulling back. And so if I look at my difference there, it's about 7. So what that tells me is I have a net force of 13 pushing materials out and a net force of only 7 pulling things back in. So that's setting up a bit of a problem. So again, when we look at our net filtration pressure, anytime hydrostatic is greater than osmotic, we said materials leave, and so they leave on the arterial end. And anytime osmotic is greater than hydrostatic, molecules and materials come back in. However, we know that we have a net pressure, right, the difference of about 13 favoring filtration, but we only have a pressure of 7 pulling material back in. So what that means, right, it's 6 millimeters more. So that means that more fluid is lost than returns back into your blood. Well, this is a problem, because if we added this up, the amount of fluid that was lost, they say it's about 3.6 liters every day. So you lose 3.6 liters every single day. Well, you only have 5 liters of blood, so how are we still up and about? Well, that's because we have the lymphatic system. So our lacteal or lymphatic capillaries are right here. And one of the main jobs of the lymphatic system is to pick up all that fluid, that 3.6 liters every single day, and return it back to your heart and return it back to your blood. So it's pretty incredible that we have this system set up. Now, the system works fine as long as our pressures are normal. But if we have any kind of imbalance in these pressures, we're going to overwhelm our lymphatic system and we're going to get edema. We're going to have too much fluid, right, accumulating in our interstitial fluid, and it will overwhelm the lymphatic system's ability to clean it up. So the two main causes, and we'll look more at this near the end of the semester with some other factors, but for this only, right here, looking at the capillary dynamics, if my capillary hydrostatic pressure went up, right? So maybe it's not 35. So we said it was 35, and then we said that we had the osmotic pressure, right, of 22, and that's how we got the difference. I'll write it right here, of 13. Well, what if I increase that to 40? Okay, well, if that goes up to 40, now I'm going to have even a greater force, right? Pushing molecules out. So it goes up even more. So even more fluid is being lost. And again, my lymphatic system can handle that 3.6 liters every single day. But if I have more fluid leaving, it can't pick it up. And so it's going to accumulate and cause edema. Well, we know that capillary hydrostatic pressure is really dependent on our blood pressure. So if your blood pressure goes up, so does your capillary hydrostatic pressure, and you can get edema as a result. Now, the other factor we look at is our capillary osmotic pressure. So again, if we go to our example over here, we have 35, right over here. We had 35, and then we had 22. And when we did the math, that's how we came up with our 13. Okay, well, what would happen if my osmotic pressure fell? So let's take my 35, I have my 35, and let's say instead of 22, I don't know, let's make it 18. I'll write it over here. Well, if now my osmotic pressure decreases, right? It's not 22 anymore, it's 18. So again, I'm going to have a problem where I'm going to lose too much fluid, right? Too much is going to go out. Now remember that my osmotic pressure was most dependent on albumin. And I had mentioned a few minutes ago 2 of the main issues that could happen with albumin. Remember, we shouldn't lose it. It should always be in the blood. Well, there's a couple organs that if they're diseased can actually cause my albumin level to fall, which would then decrease my osmotic pressure. Do you remember what they were? They were the kidneys and the liver. The liver, because it makes it, so if I have liver failure or cirrhosis, I might not be able to make the albumin. And the kidneys, because it's never supposed to leave. But if I have kidney damage, if the blood vessels in my kidney have those holes in it, like the coffee filter, now I will lose albumin in my urine. It's called proteinuria or albuminuria, and it's abnormal and it's not good because now you're urinating it all out and you're going to have edema as a consequence. So this wraps up our lecture on the capillaries, capillary pressures, and tissue perfusion.